Hi, my name is Connie Laplanis and you're watching the video on Visuoscopy. Visuoscopy, also known as fixation ophthalmoscopy, is a clinical investigation that we utilise to confirm whether a patient has eccentric fixation. So where you suspect a patient may be fixing with a point other than the fovea, you can confirm this using visuoscopy. Now, visuoscopy is essentially direct ophthalmoscopy, but using a specific target. And so whilst you're going to learn about direct ophthalmoscopy in another subject, we'll focus now on how to use the direct ophthalmoscope for the purposes of determining the presence of eccentric fixation. So with the direct ophthalmoscope, as you can see here, we'll direct the beam of light towards the patient's eye. And in this instance, we're actually going to present to them a target. And it's usually a type of graticule, such as this, that we can see here to the side, which is a network of lines. And there's a distinct centre to that. And in this instance here, the centre is in the centre of the circle here. And what we'll ask the patient is to look directly into the centre of that target. And we'll be viewing through the ophthalmoscope, and what we'll see is that that graticule will be projected onto the patient's retina. And depending on where they're fixing, we'll be able to see the foveal reflex and whether that foveal reflex is sitting in the centre as it should be. So when we look through the direct ophthalmoscope, we'll see the back of the eye, and what we're going to be looking for is that foveal reflex. And here I have it depicted as a little yellow light there. But what you'll see is when you look inside the eye, you'll get a direct little spark of light where the fovea is. So when a patient is centrally fixing, what we should see is that foveal reflex sitting right in the centre of the graticule. When there isn't eccentric fixation, we then need to classify what type of eccentric fixation it is. And here is one type of classification where we can say that it is parafoveal if it's just sitting to the side of the fovea. It's macular here if it sits at the border of the macula. And then we have eccentric fixation that can be considered to be fairly peripheral. In some other contexts, you may see paramacular as well. So there are variations in classifications, but parafoveal, macular, peripheral we'll use for the moment. Okay, here is an example of a patient who, let's say we've assessed their right eye and their left eye. And the left eye is the fixing eye here, and we can see that the foveal reflex is sitting in the centre of the graticule. Now, it's worth noting that it's always best to assess the patient's fixing eye in the first instance to afford the patient the opportunity to get used to the test and to utilise the eye usually that has the better visual acuity in performing the test so that they know what they're doing with the other eye. When you move over to the left eye, let's say that this is what you see here. So the foveal reflex is there, but now all of a sudden we can see the graticule is over to the left here. So what this is indicating is that we actually have the patient temporally fixing, and every line on that graticule indicates one prism diopter. So we actually have one prism diopter of temporal fixation in this particular instance. Now, with visuoscopy, you will remember that eccentric fixation is a monocular condition. So when you're looking specifically for eccentric fixation, you should cover the other eye. So in this instance, when assessing that right eye, that left eye needed to be covered so that you can have a look for that eccentric fixation. Now, in teaching the patient how to utilise the test, you can keep both eyes open initially, that's fine. But at the point where you're looking for eccentric fixation, you must occlude the patient. Okay, you'll notice also beneath here I've made a comment that the eccentric fixation is wandering. What does that mean? Well, what we need to indicate is whether there's steady fixation or wandering fixation. So steady fixation is when you're asking the patient to look in the centre of the graticule And assuming you've got a cooperative patient, just ask them to keep their eyes still and to continue looking at the centre of the graticule. So if you see very little movement and the graticule just sits there, so here we have a patient who's got temporal and superior eccentric fixation. If it just sits there and you're asking the patient to just keep looking steadily at the centre and it just sits there, then we've got steady eccentric fixation. However, if the patient is continually moving such like that, well then we've got a wandering eccentric fixation. What does this mean? Steady means it's well established, and that if you want to aim to treat the eccentric fixation and remove it, then that's going to be more difficult for you. It may take you longer, versus wandering indicates that you have a patient who might be easier to remove the eccentric fixation. It can also be a guide when you're treating a patient for amblyopia and eccentric fixation, whereby the eccentric fixation may begin steady, then move into wandering, and that indicates that you're being successful towards removing the eccentric fixation. How do we record the results? As you saw earlier, we can describe what we saw, and here we see we've got right steady and central fixation, left paramacular superior nasal steady. Okay, this left one could also be called peripheral, depending on the classification one uses. You can also accompany the description with a diagram, and if you're drawing a diagram, usually you'll draw the optic nerve with some vessels and then indicate the cross indicating where fixation was. So here foveal, and in this instance we can see that it's nasal and superior. And again, like I said earlier, that could be considered paramacular or peripheral depending on what classification system you're using. Okay, that brings us to the conclusion of this video. Thank you for watching.